Allow me a few minutes to start the webinar.
Yeah.
So I believe I'm visible perfectly.
Yeah.
Okay. So with all your consent, I'm starting the session, ma'am. Good
Yeah.
evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a station assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Society of Oncoanesthesia and Perioperative Care. And the topic of today's session is coagulopathy of cancer, overview and physiology. So let's begin today's session, for which I would like to hand over the session to Dr. Anjali, ma'am. Please, ma'am, over to you. Please proceed with your talk.
Thank you so much, Rupsha. I would like to thank ClearNet for their unstinted support over more than a year. This is the 57th webinar that we are conducting on this platform. And today's topic is a very interesting topic, which is crucial to our understanding of how our patients behave and what sort of anesthesia and techniques are appropriate for a given patient. And for that, chairing the session is Dr. Jyotsna Goswami. And I would like, there is nothing to introduce Dr. Jyotsna to you now. She's our president for a long time, and she has contributed significantly to the growth of the society. I would like to hand over to Dr. Jyotsna now. Madam,
Uh, yeah. Thank you, Anjali, for your kind introduction. So today's topic is very important topic, is the coagulopathy of cancer, overview and physiology. And for this topic, I invite Dr. Suparna Mitra Burman. She is a consultant in Tata Medical Center, Kolkata. She is my colleague here, and she will speak on this topic. So over to Dr. Suparna, please.
Thank you so much, ma'am, and thanks, Topsy, for giving me this opportunity to share this topic. This is a little bit vast topic. Will take time, so let's begin. So my topic, as I've already told, it is coagulopathy of cancer, overview and physiology. The topic will cover the incidence of coagulopathy associated with cancer, risk factors associated with it, pathophysiology in details, what are the assessment tools we have in our hand for further management, and what are the guidelines we have, and some recent updates. The relationship between the cancer and clotting abnormalities is recognized long year ago, even before when the cancer, how the cancer behaves in our body, how it grows, how it metastasizes, is not explained well. And it is a person who is Arnold Trossel in the year of 1965 first described the syndrome of migratory thrombophlebitis. The terminology Trossel syndrome was coined by him, which and in contrary, what happens in 2 years later, he himself was diagnosed with this syndrome on himself and succumbed to gastric cancer. So what is it? It is a migratory thrombophlebitis because of the inflammation of the veins due to the blood clot. And the thing is that it is associated with underlying undiagnosed malignancy. And this clotting can happen everywhere on the body. It can happen in the arterial flow, in the venous column, even in the heart in a form of the non-bacterial thrombotic endocarditis. It can be a thrombotic microangiopathy, or even with a excessive occlusive presentation, it can cause veno-occlusive disease. And very interesting triad, Virchow, which is very well known and very old, given by Rudolf Virchow in the year of 1856, who explained the triad, which are interrelated and always, enhancing each other to form the hypercoagulable state in a patient who are suffering from cancer. What are the three main components of it? It is the vessel wall injury or endothelial damage, which ultimately causes alterations in the blood flow in the vessels, and which ultimately leads to hypercoagulability. And these all three factors always enhance each other in a vicious cycle form, and it increases the clotting tendency. Sac et al. was a person who is in a publication broadened this term to include the chronic venous thromboembolism, which is associated with microangiopathy, platelet-rich microthrombi formation, endocarditis, and emboli in patients with cancer latter. So coming to the incidence and prevalence, do you think the incidence and prevalence is very low? No, it is not at all low. In Dutch population-based health registry, it is said that 6-month risk of VTE development, that means venous thromboembolism development, is 12-fold higher in cancer patients than non-cancer cohort. And it is 23-fold higher in patients who are on some sorts of therapy, receiving therapy, like chemotherapy or targeted therapy. And it is seen that the cumulative incidence is over the 12 months following cancer diagnosis is also very high. It is 2.3%. And it is increasing yearly. You can see in 1997, it was 1%. And now in the year 2017, it is 3.4%. And probably in the present year, it is much more higher. Mortality risk from VT is also very high. It is seen 64.5% mortality in 1 year, which is not very small percentage. And it is increased further as 88.1% after 10 years. And why this is increasing? I think that as of the availability of the advanced treatment and all this, survival is also increasing with the patients who are suffering from cancer. That's why the percentage is also increasing yearly. And bleeding tendency with this patient is also go hand in hand. It is highest with patients who are on warfarin or any sorts of other anticoagulant therapy like on rivaroxaban or low molecular weight heparin or apixaban. So in this graph from the year 1997 to 2021, you can see how the graph is gradually increasing. And in a study in Sweden, which was a retrospective nationwide case control study, included a large number of a cohort, they found that the female patients have a higher multivariate adjusted odds ratio than male patients, and highest risk was found in pancreatic cancer and brain cancer. So what are the risk factors? There are many risk factors. It can be patient-related, cancer-related, treatment-related, and some biomarker-related. Patient-related risk factors like older age, patients who are not very mobile, who are on bed rest, obesity, previous history of thrombosis, or any cause of a higher leukocyte or platelet count in the body, or any sorts of comorbidity increases the patients at risk to the development of VTE. Cancer, like a site of cancer, is very important. As I've already told, it is seen that the brain cancer, pancreatic cancers, these are having a higher risk of developing VTE than the bladder cancers or a gynecological malignancies. Stages of cancer is also very important. Advanced stage is always associated with higher risk of development of VTE. Treatment related, like any sorts of treatments, is actually prone the patients to in a hypercoagulable states, like hospitalization, surgery, any sorts of therapy like chemo or a hormonal therapy, targeted therapy, anti-angiogenic therapy, erythropoietic stimulating agents, any sorts of transfusion, any indwelling catheter in situ, or radiation. Biomarkers are also very interesting and newly added risk factors, which are widely used even in a later presentation. I will include that how they are given in score. They're using various scores like platelet count, leukocyte count, hemoglobin level, D-dimer, and some biomarkers which are not widely available. They are also now came into picture for indicating how they are as a higher value indicates the risk factors of developing VTE, like tissue factors, soluble P-selectin, factor 7. So all these are coagulation, anticoagulation factors. So coming to the pathophysiology of the cancer-related thrombosis or bleeding. So it will not be complete if I am not going to tell you about the coagulation cascade. It is a very old concept. It includes only the coagulation factors. It has two pathways, intrinsic and extrinsic pathway. In the extrinsic pathway, we know that when there is a tissue damage, there is a release of tissue factor, which activates factor 7. And this factor 7, again, this is the extrinsic pathway, then it enters into the common pathway, which activates a factor 10 into factor 10A, and this factor 10A with help of factor 5, calcium, and platelet phospholipids converts the prothrombin to thrombin, and finally this thrombin converts the fibrinogen to fibrine monomer followed by fibrine polymer. So fibrine mesh developed with the help of factor 13. Whereas in the intrinsic pathway, it includes the coagulation factors, as you can see, factor 12, factor 11, factor 9, and then it ultimately enters into the common pathway, which activates the factor 10. But the problem with this old coagulation cascade is that it is mostly explained the coagulation process in vitro. But to explain it in vivo, in detail, we need cell-based model of coagulation. So it actually consists of mainly 3 steps. It has initiation, amplification, and propagation. In the initiation phase, it forms a little amount of a thrombin, which is called thrombin spark. In the next step, in the amplification, it forms a large amount of a thrombin, which is called thrombin burst or thrombin spark. And in the next step, it causes propagation, ultimately formation of the fibrine mesh. So what happens? A little bit explanation of this is required, I think. So in the initiation phase, when there is an endothelial damage from the endothelial matrix, there is a release of tissue factor. This tissue factor will, bind with the platelet, and it causes platelet aggregation, platelet plaque formation, which is called primary thrombosis or primary hemostasis. And then this primary hemostasis itself causes lots of release of tissue factor, which with help of factor 7, which is active in a very little percentage, 0.05%, forms a teenage that is called extrinsic teenage. This extrinsic teenage then binds with factor 10 and convert the prothrombinase complex. It convert what? It activate the prothrombin, and this prothrombin then finally will form the thrombin with help of factor 5, calcium, and phospholipids. So in this way, the initiation phase, the fibrine spark happens, thrombin spark happens. In the next phase, what happens? This activated little amount of a thrombin incorporate more and more, platelet. It activates more platelets. It also helps to bind the factor 8 with von Willebrand factor, which is called extrinsic teenase. And this platelet thrombin factor 9 with intrinsic teenase with help of factor 5 then activate prothrombinase complex in a large manner, and a positive feedback effect happens, and a lots of thrombin productions then happen in the amplification phase, which is called thrombin flame. And in the propagation phase, what happens? Fibrinogen converted to the fibrine monomer with the help of this thrombin, active thrombin, and with the help of calcium, finally the fibrine monomer formed, and this fibrine monomer converted with the help of factor 30 to fibrine mesh. So you can see that how cancer cell in this diagram is actually creating a procoagulant, activates a lot of procoagulant activities inside the body, inside the vessels. It causes directly activations of the blood clotting factors. It can activate the platelet. It can also causes release of a lots of inflammatory cytokines, pro-angiogenic factors, addition molecules, and ultimately it causes, it develops an environment of the clotting. So it actually the cancer-associated thrombosis is the mechanism behind is 2 types. One is direct mechanism, another one is indirect mechanism of CAT. It is called CAT. So in the direct mechanism, what happened? It causes release of the procoagulant molecule. Tissue factor is one of the major procoagulant molecules, which we all know that how it activates other, the coagulation system itself. It also releases the vascular endothelial growth factor, which in turn causes, propagations of the tumor progression. It also releases heparinase, which again indirectly increases the tissue factor productions. It causes cancer procoagulant release, which directly can, activate factor 10, factor 7, the extrinsic and common pathway. Podoplanin is another molecule which activates platelets. And another interesting molecule is the microparticles, which you can see here that how it take parts in all the activations of blood clotting mechanisms by releasing phosphatidylserine tissue factors, and also it has a role in a neoangiogenesis. That means it not only causes the coagulation, also it helps the tumor to propagate further. And there is another indirect mechanism of CAT that causes release of various soluble mediators like inflammatory cytokines, pro-angiogenic factors, TNF, interleukin-6, E-selectin, P-selectin, which helps in adhesions, causing bridging of the tumor cells and further propagations. Neutrophil, so the neutrophil which is there inside the tumor itself releases neutrophil extracellular DNA traps, which itself causes, platelet activation, platelet aggregations. And when the environment surrounding the tumor is in stress, it releases DAMPs, that is damage associated molecular patterns, which also causes, inflammation, thrombosis. Chemotherapy is another factor which causes release of cytokines, which ultimately propagate this coagulation pathway. Hypoxia, which is there, this hypoxic environment around the tissue, tumor cells, is causing release of prostaglandin, platelet activating factor release. So that again causing clot formations. Exocytosis of the Weber palate bodies, which causes directly release of the von Willebrand factor, P-selectin, again enhance the coagulations, and some mutations of genes also causing coagulation propagation. Another coagulation abnormality which happens in the patients with cancer is DIC. DIC, we know that the disseminated intravascular coagulation, where there is systemic activation of the coagulation, which may lead to both micro, macro vessel thrombosis. So there is thrombosis everywhere that ultimately causes occlusion of a perfusion to the major organs and leads to multiple organ dysfunction syndrome. So main problem happens with DIC is there is consumptive coagulopathy, we know, there is consumption of platelet, clotting factors, also anticoagulant factors, deficiency happens. So there is increased risk of a bleeding in this group of patients. And fibrinolysis, that pathway is also activated in this group of patients that causes increased productions of fibrin degradation products. And these products, when is present in significant amount, can directly impair the fibrin clot formations, platelet aggregation. So this prone the patients to bleeding. Another very important coagulopathy or problem in a cancer patient is thrombocytopenia, which is mostly present with the patients with hematological malignancies than the solid tumor tumors. And thrombotic microangiopathy, like a thrombotic TTP, that is thrombotic thrombocytopenic purpura, or HUS, that is hemolytic uremic syndrome, seen in these patients with metastatic solid tumor or those undergoing chemotherapy with mitomycin C or platin, oxaliplatin, cisplatin group of drugs. Clotting factor abnormality is also not uncommon because there may be coagulation factor abnormalities in patients with cancer because of results of vitamin K deficiency. And we know that what are the causes of vitamin K deficiency because of malnutrition, existing liver disease, biliary obstruction due to tumor, or diarrhea, or use of vitamin K antagonists. So all this leads to vitamin K deficiency related coagulation factor abnormalities. So in the summary, I should say that what happens when the patient is having cancer, cancer cell itself enhance the coagulation process, and also this whole process, whole system helps the cancer cell to propagate. And we know that these abnormalities can be hypercoagulable state, leads to clot formation or cancer associated thrombosis formation, or it can goes to the bleeding disorders like a DIC. Okay, and this DIC will ultimately lead to hyperfibrinolysis, clotting factor abnormalities, thrombocytopenia, and all this will lead to a catastrophic bleeding in this group of patients. One terminology I should utter here, that is rebalanced homeostasis. It is always there when the patients who is suffering from some liver disease or something, where the release of the coagulation factor is, or synthesis of the coagulation factor is not okay. Simultaneously, there will be the problem in the synthesis of anticoagulants as well in this group of patients. So our body is always actually rebalanced in a homeostasis part. That's why even in the compromised condition, the bleeding due to decreased procoagulants is always get balanced with the thrombosis by decreased anticoagulants. This also happens when the patient is suffering from cancer as well. And that's why this rebalance homeostasis is actually effect, or it happens in every steps of homeostasis, like in primary homeostasis level, in secondary homeostasis level, or in fibrinolysis level. Coming to the laboratory diagnosis of cancer-associated thrombosis or bleeding. So what are the tests we have in our hand? The conventional tests like a PT, INR, we usually often raise when the patient, we have a doubt or we want to monitor the coagulation. APTT is another one. Another one is D-dimer. So the problem with PT, APTT, INR is that may come normal, may give us a normal value even when the patient is suffering from some coagulopathy, when the coagulation is not in normal. D-dimer is a very important tool or important test, which can lead us whether the patient is having a DIC or any abnormalities. Elevated level increase help to identify that thing. And that's why D-dimer is included in one of the scoring, that is CAT scoring. I will come to that part in later. Elevated white blood cell can indicate that, yes, the patient is having a coagulation abnormality, though high white blood cell can be found in many other conditions as well. Marker of hypercoagulability are there, but not widely available in our laboratories, like F1, 2 prothrombin fragment, thrombin generation test, or thrombin antithrombin complex test, or fibrinogen activator inhibitor, which indicates the impairment in the fibrinolysis. So this can help us, but not widely available. Some novel biomarker can also help us to find out the patients with cancer-associated thrombosis or bleeding. One of the novel biomarker is soluble CD62P or P-selectin, which actually incorporate again in the CAT score. And if a cutoff is there, if it is higher than that, that indicate the patient is at risk. Other like microparticles, platelet factor 4, CD14, etc. are there, but not widely available. So I should say that what practically is usable in this setting when we don't know that actually where is the problem, patient is bleeding or patient, we have to intervene the patient immediately, you have to manage the patient, then I think the point of care test like a viscoelastic test is now, tests are actually emerging, and some setups are having this facilities of a ROTEM or TEG, and they can easily use this and interpret it and manage the patient in ease. Predictive model for chemotherapy associated VT is there. So some scoring systems are there. One of the very famous scoring system is given by this scoring system, which is given by Khorana in 2012. And many people work, many researchers work on this, and they further upgraded, and many more tools are coming thereafter. So what are the components they included? They include the tumor type, platelet count, elevated white blood cell count, higher body mass index, and low hemoglobin level, and use of erythropoietin stimulating agents. And based on this, they can there is a cutoff. You can see if the 3 points more than 3 indicates that patient is at risk, so need prophylaxis. I have given here all the other assessment models available, which include CAT score, Vienna modifications of Khorana score, PROTECT-T, CONCO, ONCOTE-B, Compass CAT, and TIC-ONCO. Though I think the Vienna modifications of Khorana score can be usable where there is facility of measuring the P-selectin, because they, apart from other components of a Khorana model, they incorporated D-dimer as well as P-selectin in this scoring. So now coming to the management of cancer-associated thrombosis or bleeding and few guidelines. So we should know that in the management, we have anticoagulants in our hand, right? So what are the main anticoagulants we are using in our daily practice? So most common is the heparin. Heparin is coming as a form of a low molecular weight heparin or unfractionated heparin, where the low molecular weight heparin, with both of these components actually acting on, it's inhibit the factor 10. So the formulations are like dalteparin, enoxaparin, which can be given subcutaneous route. And another very useful anticoagulants is indirectly acting factor 10 inhibitors like fondaparinux, which can also is used as in subcutaneous route, which again, inhibit factor 10A. And direct factor 10 inhibitors, which are available in oral formulation, is nowadays in use as well as in research as well, like apixaban, rivaroxaban. Those are also very commonly used anticoagulants. So a few advantage and disadvantage, like vitamin K antagonists are used nowadays, but the problem is with the monitoring, because they need PT INR to be monitored and to be kept in a desired range to have its therapeutic effect. Whereas the LMWH is the most widely used and preferably used agents in an initial phase of treatment. And it has few advantages over vitamin K because it reduces recurrent thrombotic events without significant increase in major bleeding. And it has drug-drug interactions is also very less and shorter half-life. Whereas the directly acting oral anticoagulants compared to the LMWH has a better patient satisfaction because of the oral route of administration, though there is reports of an increase in the non-major bleeding events in this group of patients, especially in a gastrointestinal bleeding in patients with GI cancer. And drug-drug interactions is also higher in this group of anticoagulants. So there are many guidelines available regarding this, how to do prophylaxis and treatment in the patients suffering from venous thromboembolism, like ASCO, that is American Society of Clinical Oncology given, and another guidelines is given by the International Initiative of Cancer and Thrombosis, that is ITAC. There is NCCN guidelines. So I have explained, just taken for explanation, ASCO guidelines, and it is updated. It was last recommended in 2019, and recently it is updated in 2023 with considering recent 5 RCTs, especially those who are working on direct factor 10 inhibitors, and they have found that this DUAX can be an option for extended pharmacologic thromboprophylaxis after cancer surgery, but the recommendation is weak, strength is weak, and apixaban is also suggested to be added as an option for treatment of the VT, and it has a strong recommendation. So coming in the details, it has given us 6 questions and recommendations. First is about the patients who are hospitalized hospitalized for the VT prophylaxis. So what should we do? So the hospitalized patients who have an active malignancy with a higher risk of developing VTE, they should offer pharmacologic thromboprophylaxis according to these ASCO guidelines, in absence of bleeding, obviously. And the patients who are having active malignancy but without additional risk factors, they can also be offered prophylaxis. Whereas routine pharmacologic thromboprophylaxis should not be offered in this group of patients, it is said. Now, coming to the patients who are ambulatory, those who are taking treatment from a hospital in an OPD manner. So routine thromboprophylaxis for this group of patients is not recommended. It is strong recommendation. High-risk patients who are treated in a OPD manner. So according to the high risk here, they have taken the Khurana score for that. And they have considered that that thromboprophylaxis with any sorts of anticoagulants like DUAX or low molecular weight heparin can be given offered to these patients with having no significant risk factor for bleeding. And patients with multiple myeloma and those who are treated with thalidomide or dexamethasone, they should be offered this pharmacologic thromboprophylaxis with aspirin or LMWH. This is also a strong recommendation. Coming to the third question, there the category of patients is the cancer patient posted for the surgery. So all patients with malignant disease were going to be for the major surgical interventions, they should offer pharmacological prophylaxis with LMWH or unfractionated heparin, unless it is contraindicated. Okay, it is a strong recommendations. Then prophylaxis with the LMWH and or unfractionated heparin is actually preferred. It is also have a moderate recommendations, and mechanical method may be added to the pharmacological prophylaxis, but should not be as a monotherapy. Okay, and in combination with the regime of the pharmaco plus mechanical prophylaxis, this causes improve in efficacy, especially in the high risk patients. So combination is preferred. And pharmacological thromboprophylaxis, the patients for undergoing major surgery for cancer, it should be continued for at least 7 to 10 days according to ASCO guidelines. An extended pharmacological thromboprophylaxis can be given up to 4 weeks in the postoperative period, especially those who are undergoing major open or laparoscopic abdominal or pelvic surgery and having a high risk features. Now they updated that the patients who are candidates for extended pharmacological prophylaxis after surgery, they can be offered a prophylactic dose of LMWH as well. And alternatively, they can be offered DOACs also after initial period of the LMWH to these patients, though the recommendation is weak in this case. Coming to the fourth questions, this is regarding the patients who are having an established VTE. So to prevent the recurrence, they told that the initial anticoagulations may involve the use of the low molecular weight, I mean heparin or DOACs. Okay, and it is preferred that the LMWH should be used, and for initial 5 to 10 days. And for the long-term anticoagulation, they said that the low molecular weight heparin or DOACs for at least 6 months is preferred over vitamin K antagonist because of the improved efficacy and also less chances of the bleeding. And anticoagulation with the low molecular weight heparin or DOACs or vitamin K beyond initial 6 months to be given only selected patients or those who are having at higher risk of developing VT or having metastatic disease or receiving chemotherapy. Coming to the next question, where on the basis of the opinion of absence of randomized data, so uncertain short-term benefits and mounting evidence of a long-term harm from the filter. So for the IVC filter, it is not offered to the patients routinely. Only when there is an absolute contraindication to the anticoagulant therapy, only then it can be considered. It is said according to the ASCO guidelines. And the insertion of this filter can be offered as an adjunct to the anticoagulant coagulation in the patients where the thrombosis is progress in spite of optimal anticoagulant therapy. Okay, then that time you can use it as an adjunct. Coming to the central nervous system malignancies with established VTE, they have told that this should be offered, although uncertainties remains about the choice of agents and selection of the patient most likely to benefit. So you have to do here a risk-benefit ratio. Incidental PE or DVD, if there is in a patients with a VTE, it should be treated in the same manner as a symptomatic VTE. Coming to the patients group with a cancer who are receiving anticoagulants in absence of a VT to improve survival, they have told that it is not recommended to improve the survival. And what is known about the risk predictions or awareness of the VT among the patients with cancer? They have told, yes, periodical, assessment is very, very, needed. And patient education regarding the VT is also, strongly recommended. There are another guideline given by the American Society of Hematology in 2021. More or less, the guideline is same. Only I have added here a few strongly recommended parts like regarding the primary prophylaxis in ambulatory patients with cancer receiving systemic therapy. So they are they have told that low risk for thrombosis receiving systemic therapy. So no thromboprophylaxis is preferred over parenteral thromboprophylaxis. And no thromboprophylaxis is preferred over the oral thromboprophylaxis with the VK. And initial treatment with the for the patients with the active cancer VVT, they prefer that the LMWH is preferable over the unfractionated heparin for initial treatment of the VT. There are many comparison also, so I'm not going in details about this. Recommendations of the treatment of the patients associated with VT can be like this. So if they are the patient with cancer is having VTE, And there is no contraindication to the anticoagulants. Treatment with LNWH in the initial periods and then DOAC or vitamin K antagonist for at least 6 months is recommended. And if you think, and after assessment, if you find the patient, these patients having higher risk of further recurrence or something, so you need to extend the treatment beyond 6 months, then you have to decide it on case-to-case basis with intermittent risk-benefit assessment. And secondary thromboprophylaxis or observation of it is also, required if there is no recurrence, because it is not recommended to go for the secondary thromboprophylaxis when there is not elevated risk. And if there is a recurrence, if you see that, yes, there is recurrence even after that, then you can consider switch to another anticoagulants, another group of anticoagulants or you can increase the existing dose of anticoagulants, like you can increase the dose of your low molecular weight heparin. The patients with no contraindication to the anticoagulants, if there is the thrombolysis can be considered on the case-to-case basis, though it is not recommended as a primary unless there is symptomatic problem with the VT. When there is absolute contraindication, only then the role of the IVC filter came, and you have to consider it case-to-case basis. Now, approach to a critically ill, bleeding cancer patients. So, managing a major bleeding episodes in patients with a cancer is always multidisciplinary effort. And I'm going to give you a core process which can help you to, evaluate and manage this group of patients with 5 steps. It includes damage control resuscitation. You have to identify the underlying coagulation abnormalities. You have to restore whatever coagulation system or fibrinolytic system is on to its optimal. Whatever the sources of the bleeding, you have to control it in a surgical way or in a radiological or endoscopic interventions. And you have to obviously correct the underlying cause. So what is damage control resuscitation? This is a terminology which was actually originated from the soldiers who were suffered from trauma in battlefield, and later it was extrapolated to the civilian trauma. The core principle behind this damage control resuscitation is you have to avoid the lethal triad of coagulopathy, which includes a hypothermia, metabolic acidosis, and coagulopathy. So this vicious cycle shouldn't go on for a long time because it ultimately causes irreversible shock. So the algorithm actually incorporate the early administration of the blood products and don't go for flushing the patients with lots of clear fluids, because ultimately it will not improve the oxygen supply to the vital organs, but it will overflow the patients with overweight the lung. European Society of Intensive Care Medicine guidelines gives us an empiric fixed high transfusion ratio of 1:1:1 of the RBC platelet and FFP. Platelet and a plasma that can be given, and the platelet and plasma in acutely bleeding cancer patients should be used with your clinical judgment and whatever test you are available with. Especially in this scenario, PO point of care tests are very helpful. Several professional associations guidelines are there, latest by the American Association of Blood Banks, who recommends that the hemoglobin trigger in this resuscitation where the patient is hemodynamically stable can be between 7 to 9. So this damage control resuscitation goals incorporate control bleeding, maintain ABC, and prevent coagulopathy, hypothermia, and acidosis, and early blood product transfusion with limiting clear fluid transfusion, coagulopathy evaluation again and again, and early restorations of the system, abnormal systems of coagulations or fibrinolytic pathway, rapid anatomical control, that means cessation of the source of the bleeding, and hemostatic adjuncts to be used accordingly. So you have to identify where the coagulation abnormalities lie. So as I've already told, that intrinsic pathway which can actually be tested with the APTT, whereas the extrinsic pathway which can be tested with PT INR. This can give you a false positive result or false negative result when the patient is actually in a coagulation altered environment. So this is the summary of the laboratory test of coagulopathies, like with patients with liver dysfunctions, vitamin K deficiency, and these are the problem, and these are the tests which can identify the abnormalities. But again, the problem with this is that it sometimes may not help you. So why there is a disadvantage? Because it will not give you a global view of the whole process of the abnormalities. INR is actually not calibrated to a specific changes of the liver-related coagulopathy specifically. There is no evidence that a prolonged PT or INR is an indicator of hemorrhagic shock risk related to invasive procedure. It is sometimes found that the higher PT INR, but the patient is not bleeding. Correlation of the fibrinogen with the bleeding risk is also not defined. Cutoff values of platelets below which the risk is actually enhanced is not clearly known. Hypercoagulation status is very difficult to demonstrate with this conventional test. So now there is actually the role of this use of the viscoelastic test. So we have TEG, Rotem with us, and this helps us because it gives us a global picture of the coagulation pathway of the patient at that moment. It gives us the dynamic assessment, which involves the clot development, growth of the clot stability, also include the fibrinolytic pathway. So I am going to explain more little details about the Rotem device, where it gives us the thrombin generation, clot firmness, and clot stabilization. And where the problem is there, you can easily find out, and there are various tests to address those specific pathway. Like in the Rotem, if you do the XTEM, it will give you the overview of the problem in the extrinsic pathway. Whereas if you raise the INTEM, it will obviously, XTEM will also give the common pathway. And in the INTEM, it will give you the overview of the intrinsic pathway with common pathway. Whereas in the FIPTEM, you can easily identify where whether the clot firmness deficiency is because of the platelet or it is because of the fibrinogen deficiency. In the ACTEM, it will help you to evaluate in details about the fibrinolysis part. So it has, I have already told, it will give you details of a thrombin generation, clot firmness, and clot stability. So as you can see in this picture, in the thrombin generation part, which is actually represented by this clotting time, because of the, why this clotting time happen, it is because of the effect of the coagulation factors. So if there is deficiency of it, this CT time, that clotting time will be prolonged. And in the XTEM, this clotting time prolongation is due to the problem in the extrinsic pathway. In the INTEM, this prolongation is due to the problem in the intrinsic pathway. Now coming to the clot firmness, where in the picture you can see it is represented by the clot strength, and the points here will be the amplitude. And there in this Rotem, they have taken amplitude at various time point, at 5 minutes, at 10 minutes after CT. And the maximum clot firmness is represented by MCF. So clot firmness is actually, give you the idea about the fibrin polymerization, whether it is due to, both contributing factors of fibrin and platelet. And if you find that the patient is having low MCF or a low A5 or a A10, you can further order FIPTEM, which will help you because FIPTEM will actually abolish the effect of a platelet. So it will give you the MCF only which is formed by the fibrinogen. So if there is if that is also low, that is due to only fibrinogen only. And if it is normal in the FIPTEM, MCF breadth is normal in the FIPTEM, but it is less in the XTEM or INTEM, that indicates that there is actually problem in the platelet pattern. In this way, we can differentiate whether the problem there is in a platelet or in the fibrinogen part. And In the last part, as you can see, the clot stabilization, which is actually influenced by the fibrinolysis and platelet-mediated, clot retractions. There, they are measuring the maximum lysis and lysis index at various time points of 30 minutes, 45 minutes, 60 minutes. And more is the lysis, it will be more, more shorter. So the ml, that means maximum lysis, if it is greater than 50%, or lysis index 30 less than 94%, or lysis index 60 less than 85%, this indicates hyperfibrinolysis. Whereas reverse will happen if the patient is having DIC. So this can further in details, can be evaluated if there is a fibrinolysis, deficiency of fibrinolytic agents or not by the APTEM test. So this I have already told you that how the various tests in the ROTEM can, evaluate which part of the coagulation pathway is actually affected or not properly. Pathology lies in which part. These are the ROTEM parameters, and based on the findings of your test, you can easily treat the patients in a goal-directed manner with your test results. So how it can be? Goal-directed hemostatic therapy can be like this. So this is actually, there is no paper is available for the patients with cancer, but this is mostly extrapolated from the patients who are having trauma or a cardiac patients. Is like that. You have to raise extem, intem, fictem, aptem for the patients who are significantly on bleed, especially in the perioperative period with associated sepsis or anything. I mean, when the patient is at risk of bleeding and the patient is bleeding on table, you can raise any of these tests, all these tests actually, and you have to step by step go downwards to find out at which level the problem lies. Like in the step 1, you have to see in the fictem maximum lysis, and in the extem also you have to, that means in the step 1 you have to correct the hyperfibrinolysis. So if you find that the lysis is very shorter, that can be easily corrected with the tranexamic acid. In the next step, you have to see in the extem the maximum MCF, that is a firmness, that is a breadth of the MCF level. So if you find that this is shorter, this is not okay, that indicates that there is a problem in the fibrinogen or the platelets. To differentiate it, you have to see the fictem again, and from there you can easily find out which component is deficient there, whether fibrin or platelet, and you have to treat accordingly. If that is also normal, then you come forward and you try to find out whether there is any problem in thrombin generation or not. That can be picked up with the value of the CT. And if the CT is prolonged, obviously that indicates there is a problem in the coagulation factors. And you have to correct then the coagulation factors, like that what are the coagulation factors involved in intrinsic pathways. So from the intem, if you find that the CT is prolonged, that means obviously it includes those factors. If you find the CT is prolonged in the extem, then obviously it includes the deficiency in the factor 7. So you have to go more towards the goal-directed corrections of the factor 7. So various factors are available. I'm not going in details what are the factors containing, what are the components containing what are the factors. And so in this way, in this manner, all the phases of the coagulation can be corrected in goal-directed manner using this point of care tests. Now, a little bit knowledge of the reversal of anticoagulation is also required, because most of the patients we are receiving are on some sorts of coagulants, anticoagulants agents. So if the patient is bleeding, you have to reverse it then and then. So this is the table where you can easily see that what are the factors can reverse what. Like warfarin can be reversed with reversal agent vitamin K, and you have to monitor with the INR value of the reversibility. Whereas the low molecular weight heparin or unfractionated heparin is reversed with protamine sulfate. Dose is given over here. And the directly acting factor A inhibitor, factor 10A inhibitors can be reversed with 4-factor prothrombin complex, and whereas direct thrombin inhibitors like dabigatran can also be, reversed with a 4-factor prothrombin complex. So the knowledge of this is very important, because sometimes you find the patient is on this anticoagulants and you have to reverse it on table or before, pre-operative, before surgery. So management of the acute hemorrhage can be done in this way. Bleeding cancer patient on table, if there is a massive hemorrhage, you go with a fixed dose transfusion strategies, like you can use 2:1:1 ratio of a blood transfusion. And after initial, transfusion, you can go for the further laboratory test of finding out the value of fibrinogen or D-dimer, or you can use the other PT, INR, and point of care, obviously use of point of care testing, and based on that you can further consider which component is required for the patients. In a non-massive bleed, you can target hemoglobin 7 with a limited clear fluids, and you further do assessment, and then you do the goal-directed management. Along with that, resuscitation is always there with airway, breathing, circulations, and preventions of the lethal triad of hypothermia, hypercoagulability, and all this, and also corrections of electrolytes, all the reversible causes. So these are the targets you can keep in mind while resuscitating the bleeding patients. And if you find the patient is hyperfibrinolytic state, you can consider tranexamic acid, even if there is a severe bleeding you find out. And always be ready with the anticoagulant reversals as and when required. Coming the last part of my presentations, a little bit about the disseminated intravascular coagulations. Sometimes the cancer patients, especially in the advanced stage, are in sepsis or in advanced, other medical comorbidities. Especially, I should say, sepsis. This always, trigger the patients to go into the DIC. Even after a major surgery, after sepsis development and all, these patients usually land up in this DIC. And this patient, when again come back to OT for a further surgery, this is a difficult job for us to manage this kind of a patients. And the acute form of DIC, which can be a catastrophic result of a sudden widespread coagulation, which leads to consumption factors and the platelets and a hyperfibrinolytic states. So this leads to unstoppable hemorrhagic bleeding and hemorrhage basically. And it causing a lots of modes. I mean lots of damage to the vital organs, and the most important organ which is affected is renal, followed by liver dysfunction, CNS, and CNS. In the chronic form, when the patient is suffering in the ICU for the longer time with a solid organ tumors, they can also have DIC, but may not be they are having an active bleeding. But these patients, when taken for the surgery, will be challenging for us. So how to diagnose this patient and manage these patients? Again, I should say that the routine tests like a PT, INR, APTT, those may be found prolonged, but how to take, what cutoff should take to manage this patient, we don't know. And also, it is more marked, this prolongation is more marked when the patient is in an acute state. So the test results may differ in a patients who are in acute or in a chronic. So that may be a determining factor. Fibrinogen level, which is low in acute DIC, may be prolonged in a chronic phase. D-dimer is another marker which is elevated in both acute and chronic phase, and another is platelet count that can be low because of the consumptive coagulopathy. So what I have find out that this group of patients been taken for surgery. Recently we did a surgery, and in a patients who are a sepsis in DIC, and we take the help of the ROTEM there, and you can see here in the ROTEM how broad is the clot firmness. Clot firmness is not at all, I mean, the lysis is not at all there, and it is MCF is broadened like anything. So we tried to find out which part was problem, which part of a coagulation pathway is affected there, and we corrected. Like here, we found that the CT was prolonged in TEM, and we corrected it with a prothrombin complex, and the patient did little well after that. So goal-directed blood management is actually we are using now, and we can understand that how helpful it can be even in this scenario. And there is the diagnosis and scoring system for the DIC. So International Society for Thrombosis and Hemostasis given as a score, which include the platelet count, fibrinogen, D-dimer, and INR. And the score more than 5 actually, needed is the diagnosis for the DIC. Another scoring system given by the Japanese Society of Acute Medicine. And they use antithrombin instead of fibrinogen and change in the platelet count as a supplement to absolute platelet count. In the management, I should say that the British Committee for Standard in Hematology, they have given us a guideline for this, and we can extrapolate it and use it. So it has 3 phases. Pro-hemostatic blood products should be, used. So prophylactic platelet, FFP, or a cryoprecipitate transfusion, they have said that it is not advisable based on laboratory test alone, where especially the bleeding is not there. And platelet transfusion also in actively bleeding patient or at a high risk of a bleeding patient, especially in the post-surgical conditions, or require urgent interventions, then only, you transfuse platelet and otherwise not. And platelet transfusion is considered only when the absolute count of platelets is less than 10,000. In that case, even without bleeding, in a high-risk patients where there is a chance of a spontaneous bleeding, you can transfuse platelet. For the FFP, yes, in active bleeding and prolonged PTA-PTT, they consider the FFP transfusion. For the cryo, they told that should be transfused only in active bleeding patients and where the fibrinogen level is less than 100 only. Coming to the anticoagulants, according to that guideline, thrombosis, predominant features, such as in a major vessel thrombosis, or when there is an organ dysfunction, limb or a digital ischemia is there, then therapeutic dose of heparin they're considering. And LMWH or unfractionated heparin prophylaxis is given only to the critically ill non-bleeding patients with DSC. So in that case, you have to judge on case-to-case basis, basically, because you have to weigh this benefit in this scenario. Antifibrinolytics agents, routine treatment is not recommended, as inhibitions of this pathway is actually carrying this patient's group to more towards increased thrombotic complications. Tranexamic acids can be used in selected cases of active bleeding. So my take-home message will be like bleeding and coagulopathy is a very common, is a multifactorial, multidimensional, and a thorough understanding of the pathology physiological process is very important to intervene your patient. In massive bleeding condition, yes, fixed dose ratios are actually recommended to minimize dilutional coagulopathy, because once that triad is triggered, it will go in a vicious cycle and deteriorate the conditions of the patient. Clinically significant but not massive hemorrhage when is it there? Restrictive approach is much more preferable to the blood product replacement. And pro-hemostatic therapy should be guided by, not blindly, but it should be guided by laboratory tests or point of care testing of coagulations. Viscoelastic testing, which is emerging nowadays, is a very good tool for a goal-directed hemostatic therapy, which reduce blood products, transfusion, and this transfusion-related huge lots of complications. And knowledge of anticoagulant use and its reversal is very, very important to prevent severe bleeding as and when required. So thank you so much for patience listening.
Thank you, Suparna, for it's an exhaustive talk and finished in 1 hour exactly. So we have some questions to address. First question is from Dr. Kusuma Parikh. She asked about the renal carcinoma with IVC thrombus posted for surgery. Is IVC filter recommended or not?
No, actually, ma'am, IVC filter is is as a primary approach to the treatment is not recommended anywhere. It is only recommended in few restricted scenarios, like when the anticoagulants are absolutely contraindicated, or in a patient who has existing thrombosis and it is propagating, it is continuously increasing in spite of optimal dose of anticoagulants. Only those cases it is indicated according to the guidelines.
Okay. Yeah, it is so. It's like that. And only it is absolute contraindication of anticoagulation, then only you can think of. Otherwise, the renal carcinoma with IVC thrombus, it can be done as it is total nephrectomy along with the radical nephrectomy along with IVC thrombectomy. So usually IVC filter is not required that time. Okay. We have another question. Peak line with upper lip DVT
Yes.
with platelets 15,000. What is the best way to manage?
Okay, so patient is having thrombus already because of the line related.
Okay.
So
Got the question, Shubha?
yeah, I got the question. So as the patient is already developed thrombosis, which is localized there, and because of this catheter, they should be on the low molecular weight, I mean a heparin therapy, anticoagulant therapy for that till the line is there. And if the platelet count is 15,000 and patient is not bleeding, in that case, the transfusion of the platelet is not recommended. If the count comes below 10, I mean 10,000, and patients with having associated other elevated risk of bleeding, that time you can transfuse platelet. Otherwise, with 15,000, according to guidelines, it is not indicated. But patient should be on anticoagulant therapy for that till the line is there. It's a prophylactic. It should be prophylactic.
Count is less than platelet count is less than 30,000. So I think it is recommended that you should give heparin or fondaparinux or something, anticoagulant therapy. You should give a 50% dose if the platelet count is very low.
Yes.
Okay, any other question? 1 minute. No other, I can't see any other question. Okay. So what you suggest that any time any cancer surgery with major cancer surgery, we should always assess first how is the risk factor for the thrombosis or the bleeding, and accordingly you can most of the cancer patients are prothrombotic. So we should assess first the risk assessment and then the starting of anticoagulant. That is the main thing to be done for any kind of cancer surgery, right?
Yes, for any sorts of major surgery, they are recommending for going for the prophylaxis as well as post-operative extension of the anticoagulant therapy. Because it itself is a surgery, itself is a elevated risk for development of VT, and especially when the surgeries are involving the abdominal surgery, pelvic surgery.
So when this extended, yes, and when you recommend that extended prophylaxis.
Yes, so when the surgery is a major surgery, as I've already told, that in a major abdominal surgery or a pelvic surgery, in that case, they are recommending to extend it for 4 weeks. Post-op period, and beyond 4 weeks, whether to continue it or not further, then you have to reassess the patient. If the patient is still having existing risk, elevated risk, and then case to case basis you can reconsider for further long-term extension. But up to 4 weeks after major surgery, it is recommended to continue anticoagulant therapy.
Question I can see in the chat box. So time is up. Anjali, anything you want to discuss? Then 1 minute. Yeah, one more question, Suparna.
Yes.
Rotem or TEG won't be available in all centers. So which is the next best investigation that can be done to assess coagulopathy?
So then in your hand are the conventional tests like PT, INR, assessment of the fibrinogen level, D-dimer. All these are conventional tests are only there in your hand. Platelet count. So you have to go for the conventional test only. And you should know that which test will be abnormal at what level, what abnormal, I mean, which abnormal part of the coagulopathy. I mean, which part, like APTT, it actually indicates the abnormality in the intrinsic pathway. Like PTINR, it indicates the abnormality in the extrinsic pathway. So that you have to know. In that way, in an indirect manner, you have to intervene. Otherwise, POCT actually is the best thing, because even if you find in a conventional test like PT-INA specifically higher or lower, it doesn't give you the true picture of the coagulopathy. So that is the thing. So this is more like blind approach to the management of the patient. So
Yeah.
CT is always better.
It is a dynamic. It can give the idea of the dynamic process. So otherwise,
Yes.
it is any lab test. Anything is a static one point time you can see, and it's not a global test. So that is why POCT is always better. But if it is not available, then you have to depend on the lab test, on the conventional lab test.
I think you have to take a sort of an integrated approach if you don't have POCT,
Yeah.
and it all
Exactly.
devolves to your understanding of what is
Yeah.
going
So
on in toto,
yeah,
along with the
many a
clinical
time.
test and the clinical picture and the test. You have to
Mm.
integrate that and come to a
Yes.
decision pathway.
Yes. So anything else, Anjali, you want to discuss?
No, I think that was a very comprehensive coverage of a very difficult topic, to be very honest.
Yeah.
And I'm impressed by how in-depth the coverage was as well. So thank you.
Okay, so then we come to an end,
And
so you can
thank you.
end the session.
Thank you, Dr. Jyotsna, for your able guidance.
Thank you.
Okay, I just wanted to say to everybody a very happy Teachers' Day to all of you. We are nearly in the waning phase of the day, and I hope you have a
Yeah.
lovely evening.
So happy Teachers' Day to everyone. Everyone is teacher actually. We learn from each other. So happy
Yeah,
Teachers
it's
Day
just
to
a process
everyone.
of learning, whichever stage you are at, you're still learning.
Exactly.
So
Exactly.
thank you so much. And may I hand over to Rupsha now to conclude the session?
Thank you, ma'am. Thank you so much to everyone for extending us the opportunity to host this session. So with this, we would like to conclude today's session over here. Looking forward to host you again. And last but not the least, wishing a happy Teachers' Day to all of you. Thank you so
Thank you so
much.
much. Good night.
Thank you. Good
Thank
night.
you. Good night.